Tēnā koutou katoa. Right, so as has been mentioned, I'm the lead chief executive. I chair the governance group for this process. I had that thrust upon me about 3 years ago when I said I'd take it on for 6 months, and here I am 3 years later. So, and I wasn't here at the start of the process. I wasn't involved in establishing the contract, and I think, you know, when you look back at the way that the contract was established, I think we're trying to learn some of the lessons in the way we're trying to develop this round of the contracting. So CPSA 12 was developed using a collaborative model, trying to bring parties together, and those parties were pharmacists, particularly community pharmacy, the Ministry of Health, Pharmac, and the DHBs. I won't take a genius here to spot some of the people who weren't around the table at that point, but there's some of the people that are on the table here today. It did, however, signal a change in the way that DHBs were contracting for pharmacy services in the community and trying to introduce a new service model designed to support pharmacists in the provision of enhanced services to consumers, particularly those who needed help managing their medicine. So a movement away from simply a dispensing service. The intention in the contract was to be more transformational in community pharmacy and to move the focus, to shift the focus to service delivery and an attempt to put the patient at the centre. So that was the intention behind the contract. And so an attempt to develop a more patient-centric service, but also a recognition that if you look at the growth in funding going into pharmacy at the time, it was on an unsustainable pathway. So we were looking at 7-8% per annum growth, which is way beyond the rest of the sector. So an attempt to make the service more patient-centric, to have pharmacists operating more at the top of the scope, and also to constrain costs. So that was what we were trying to achieve. Did we achieve that? So any transformational change process of this kind needs some kind of evaluation. And we commissioned an evaluation using CPSA in 2015. So an independent evaluation to see had we fulfilled some of our key outcomes. And those were the outcomes described. So incentivize patient-centered approach to medicines management, to shift the focus from dispensing to the provision of professional advice and support, increase collaboration of the patient's multidisciplinary team, sustainable community pharmacy services and value for money for district health boards, and funding incentives to align with services that improve medicines adherence. Now, if you look at that list of intended outcomes and reflect back on who was involved at the start of the process, it wouldn't take a genius to work out that actually you're probably not going to achieve all those outcomes, because we started, one of our outcomes is to incentivize a patient-centered approach to medicines management, but we didn't involve consumers. And we intended to increase collaboration of the patient's multidisciplinary team, but we didn't involve the multidisciplinary team. So it's kind of not surprising that we didn't necessarily fulfill all the outcomes. Hopefully we'll rectify some of that through this process. So what did the independent evaluation tell us? It told us that, I mean, it was a kind of the top one is a half a tick, I think, step in the right direction, but actually we were unable to demonstrate any significant health benefits as a consequence of the process. So you could argue it's a step in the right direction. You could argue actually a lot of process for not a lot of outcome. So I think it's maybe an attempt to do the right thing, but I think we could do better on that. CPAMS, the Community Pharmacy Anticoagulant Management Services, was liked by all parties where it was taken up. And last but not least, and I guess whether this is a success or not depends on where you sit on this, a lower funding growth. I think for DHBs that would be seen as the biggest, in many ways the biggest success of the process, and it's got us on a more sustainable funding path. But I think a pharmacist the Pharmacy Guild might have a different view. Ken, you can. What could have been done better? I think we had a number of transition stages, which sometimes we've struggled to meet, and that's created sometimes kind of chaos and confusion, and it's been unhelpful. So whatever we come up with now, we don't want to have a whole series of transition stages that we're struggling to meet. The transparency of the payments and the service specification, particularly the payments. It seems to me that people are quite confused about what they get paid, how they get paid, how you work it all out, and that it's got to be clear to pharmacists what they're getting paid for and why. Yes?
I think you need to remember too that the consumer is going to need to have clear guidelines as to what they pay for, what they don't pay for.
Yeah, I completely agree.
Like, we've got all these notes, we get involved with everything, yet we ourselves don't know where the consumer.
Yeah, completely agree with that. Good point. And if we're going to evaluate, then you've got to have a baseline. And I think one of the problems with the evaluation is not actually having a clear baseline that you're measuring against. So you build in your evaluation right at the start of the process, and then you evaluate. I think also what we haven't mentioned here for me is at the start of the process we didn't have the infrastructure that we have now to manage the contract, and that was part of the reason why it was a struggle to deliver many of the things we wanted to deliver, whereas now we've got a clear infrastructure that supports the process going forward. So, where to next? Well, this is the process that we're in. We need to, we recognise that there is widespread variability in the sector. Population need differs, so we need to, in any process going forward, need to reflect that. And I think it's important to agree what are the things that need to be common nationally, but where are we going to allow local variation, and that needs to I think, be much greater than we've delivered in previous contracts, to cater to the needs of the different populations, and also to the variations that we have in pharmacy models, and also recognise that there are benefits from the ways that we can use small businesses like pharmacies to complement the large organisations of district health boards. Sometimes can be move much more quickly as a smaller organisation, and that can be very helpful. So we're not going to a one-size-fits-all in the future. We can't meet the needs of the New Zealand consumers by having one-size-fits-all across the country, and we need to be much more flexible in the way we deliver our contract and our services in the future. Those are my thoughts for the day. Thank you.